Good afternoon, friends. I'm Dr. Rohit Prakara. I'm neurology faculty for Prakara. So, in this session, the next 1 hour, we'd be discussing how to approach a question paper on clinical neurology. Let us start with the essay questions. The first question that was asked was write in detail about Guillain-Barré syndrome. So, as we all know, Guillain-Barré syndrome is an acute peripheral neuropathy. It's an immune-mediated acute polyradiculopathy. So, Guillain-Barré syndrome is a heterogeneous group of immune-mediated conditions with an incidence of around 1 to 2 per 1 lakh in a year. So, there are many variants of Guillain-Barré syndrome. So, once we define Guillain-Barré syndrome, we need to describe the variants. So, what are the known variants? The variants could be electrophysiological variants or clinical variants. The important ones are the electrophysiological variants, which are AIDP, that is acute immune mediated demyelinating polyneuropathy, or AMAN, which is acute motor axonal neuropathy, or AMSAN, which is acute motor sensory axonal neuropathy, or the fourth rare variety called Miller-Fisher syndrome. So basically, this classification is based on the electrophysiological pattern, the underlying pathophysiology, where the polyneuropathy can be of axonal degeneration or of demyelinating type. If it is demyelinating type, it falls into the category of AIDP, acute inflammatory demyelinating polyneuropathy, while the axonal forms are called AMAN, AMAN, AMSAN, AMSAN, or the other variant is Miller-Fisher syndrome, which is a rare variant. So usually in the Western population, the demyelinating neuropathy is found to be common, but in Asians, especially Chinese, Japanese, and Indians, the axonal variant, especially Aman, is also quite common. Uh, Most of these, at least 10 to 30% of these infections, they are 10 to 30% of patients with Guillain-Barré syndrome, we find that there is a preceding infection which triggers the immune response in that particular individual. So this infection is most commonly found to be because of Campylobacter jejuni, which can cause diarrhea probably a week or two earlier to this before starting of symptoms. But not just Campylobacter jejuni, any infection for that matter. It could be pneumonia, it could be non-specific viral infection, it could sometimes be dengue infection also. So all these infections can trigger the immune response in the individual, leading to development of acute polyneuropathy. The hallmark of GBS or Guillain-Barré syndrome is acute paralysis evolving over days to weeks with loss of deep tendon reflexes. About two-thirds of these cases have a prior history of infection, and resultant autoimmune response triggered by this infection leads to demyelination or axonal degeneration. So what are the clinical features? Distal paresthesias and pain. Distal paresthesias, which is predominantly in the legs, in the feet and hands, as well as pain, precede the development of weakness. And this weakness rapidly ascends from lower limbs to upper limbs, and it may involve the bulbar muscles, which is the cranial nerves, or it can also involve the respiratory muscles. So that's why it is known as ascending paralysis, where the lower limbs are first involved, but the upper limbs also are it spreads rapidly to involve the upper limbs as well. And there is possibility of respiratory weakness and bulbar weakness in nearly 20% of these individuals. And in these patients, what is found that predominantly the proximal weakness is found to be more than the distal weakness. This weakness progresses over a maximum of 4 weeks. So from the onset of symptoms of paresthesias or pain, the maximum deficit, that is the nadir, we call it, is seen up to 4 weeks from the onset of illness. Rapid deterioration to respiratory failure can also develop in certain individuals. On examination, we find diffuse weakness with loss of deep tendon reflexes. In rare varieties like Miller-Fisher syndrome, they present with ophthalmoplegia. It could be internal or external ophthalmoplegia along with ataxia and areflexia. So these are, we have discussed the electrophysiological variants. Sometimes there can be clinical variants also. Clinical variants in the form of paraparetic variant, where only the lower limbs are involved, or sometimes it could be pure sensory variant, where only sensations are affected, but limb power is not affected. Other rare clinical variants are acute pan dysautonomia, where there is no weakness, but there is autonomic disturbance in these individuals. Or sometimes there is another variant which is called pharyngobrachiofacial variant, where predominantly there is facial paralysis, there is difficulty in swallowing, and then there may be upper limb weakness, which is called pharyngobrachial or faciopharyngobrachial variant. These could be the clinical variants of Guillain-Barré syndrome, and that concludes the presentation on clinical features part. Now let's move on to investigations which are required in a case of Guillain-Barré syndrome. Once you have a clinical suspicion of Guillain-Barré syndrome, we do electrophysiological studies. Electrophysiological studies in the form of nerve conduction studies, or sometimes even needle electromyography. What it reveals is, it reveals the subtype of uh, the acute polyneuropathy. NCV, nerve conduction studies, help us differentiate between demyelinating and axonal forms. In demyelinating forms, there is prolonged distal latencies and there is reduction in nerve conduction velocity. Whereas in axonal forms, there is reduction in motor, or probably motor and sensory amplitudes. But the catch is that nerve conduction studies can be normal in the first 1 week to 10 days. So in cases where it is ambiguous, or where the diagnosis is not clear, we move on to do another test called lumbar puncture and cerebrospinal fluid analysis. We do this because in Guillain-Barré syndrome patients, there is a phenomenon called cytoalbuminological dissociation in CSF. That is, in CSF, the protein levels are elevated while the cell levels, which is the WBC counts in CSF, tends to be normal. So this is called cytoalbumological dissociation, where the albumin, that protein levels are elevated, but the cell count remains normal. So this is another test that will add to our diagnostic certainty. Of late, there are certain antibodies which have been developed, which have been found to be associated with Guillain-Barré syndrome. These are called anti-ganglioside antibodies. Examples are anti-GM1 antibodies or anti-GQB antibody, GQ1B antibodies. Sometimes we might have to differentiate it from other causes also. So our differential diagnosis should include myasthenia gravis, myasthenic crisis, poliomyelitis, botulism, diphtheria, or spinal cord syndromes like transverse myelitis. So once we have diagnosed it, how do we manage? So there are two main modalities of treating Guillain-Barré syndrome patients. One is intravenous immunoglobulin injections. So we give these injections over a period of 5 days. So there is a specified dose according to the body weight of the patient. So we give these injections spread over 5 days. Or the second modality is called plasma exchange. So plasma exchange is also done in 5 sessions, preferably on alternate days. So once these plasma exchange is done, what we do is we try to clear the antibodies from the patient's plasma, so that the symptoms of Guillain-Barré syndrome are first arrested, and then the patient recovers later. In addition to this main treatment, we need there's a lot of supportive care that these patients need. Mainly, we need to prevent pressure sores in them, because they are bedridden. They tend to develop pressure sores, and then we also need to prevent deep venous thrombosis. So DVT prophylaxis, it could be physical in the form of pneumatic compression devices, or we might have to resort to pharmacological DVT prophylaxis also using anticoagulation. So that concludes our first question, which was on Guillain-Barré syndrome. Let's move on to 1B. So this question is discuss in detail about etiology, clinical features, investigation, and management of head injuries. So we all know head trauma or head injuries, they can range, they have a wide range of implications basically. So head injuries can range from simple scalp lacerations, which is nothing but the skin, uh, scalp lacerations, to serious, uh, serious debilitating conditions, which can lead to persistent vegetative state like diffuse axonal injury. So if we look at the anatomical structure of the head, the injuries can lead from a scalp laceration, which is extracalvarial. It can lead to skull fractures. A head injury can lead to various kinds of hemorrhages inside the brain or within the coverings of the brain, which are called the meninges. Or it can lead to intracerebral hemorrhage, or it can also lead to diffuse axonal injury, which is the worst form of head injury or traumatic brain injury. So, two or three lines on the introduction, and then we quickly move on to etiology. What are the causes of head injury? Most common causes are road traffic accidents or motor vehicle accidents. Then the other causes could be falls. Falls could be triggered or falls could be spontaneous. So, for example, spontaneous falls happen in elderly patients with movement disorders where they have gait instability. In them, there can be falls, unprovoked falls, or provoked falls could be because of slipping or tripping over objects or some other mishap. And the other causes of head injury are assaults. Sometimes there can be assault cases where they end up with head injuries, or they can be bullet wound injuries, though rare, but these are also very important forms of head injuries. And then people living in war zones, they're exposed to a lot of explosives and shrapnel. They also uh, can present with head injuries. And then uh, individuals involved in contact sports, for example, rugby and or boxing or wrestling, all these patients can have head injuries. And yeah, I think that completes the causes of head injuries. Then we move on to the clinical features. Clinical features, depending on the severity of brain injury, clinical features also can range from very minor headaches, minor simple symptoms to serious comatose conditions. So before proceeding to clinical features, let us discuss what are the various kinds of head injuries. So as I described earlier, the first could be scalp lacerations, and then there could be skull fractures. After skull fractures, there could be concussion. What is concussion? Concussion is one of the milder forms of traumatic brain injury, where the brain parenchyma is intact, but there is transient neurological deficit, or which can include even lapse of consciousness for a while. So concussion patients, they may lose consciousness. They can sometimes have seizures, but when you do their brain scans, their brain parenchyma is normal, and there is no hemorrhage in their either inside the brain or outside the brain. So after concussion, let us discuss various types of hemorrhages that you see in traumatic brain injury. First is the extradural hemorrhage. Extradural hemorrhage occurs, there is accumulation of blood or hemorrhage between the skull and the meninges. That is the uh, epidural layer. Epidural layer, as we know, is the outermost layer of the meninges. So when there is hemorrhage between the skull and the epidural membrane, it is called epidural or extradural hemorrhage. Then there could be subarachnoid hemorrhage. So subarachnoid hemorrhage occurs between the arachnoid space that is the meninges and the brain parenchyma. This is known as subarachnoid hemorrhage. And then we also have subdural hemorrhage, which is between the dura mater and the arachnoid. So here in subdural hemorrhage, the hemorrhage is between two layers of the meninges. So These are the hemorrhages that occur outside the brain parenchyma. Sometimes the hemorrhage can be inside also, which can include contusions. There can be hemorrhagic contusions in the brain, which is mainly due to the counter coup forces. That is, when the skull hits an object hard, the brain inside the skull wall, it hits the posterior aspect and then comes back. So when there is that rapid accelerating and decelerating force, there can be counter coup contusions. And after contusion, we can also see intraparenchymal hemorrhage or intraventricular hemorrhage, where there is hemorrhage within the parenchyma of the brain, or sometimes even in the ventricles. And the last or the most serious part, or the which because uh, it is known to have a very bad prognosis, is diffuse axonal injury. Diffuse axonal injury occurs because of shearing forces between the layers of cells of the brain parenchyma, where there is disconnection between multiple layers. It leads to the most severe form of traumatic brain injury, where patients might remain comatose for months, or they may even succumb uh, because of the head injury. So the clinical features can range from mild headache to periorbital edema, periorbital ecchymosis, or bleeding from the ears, bleeding through nose, or patients can have vomiting, and some patients can have seizures. Some can have loss of consciousness, and if there is hemorrhage anywhere within the parenchyma or outside the parenchyma, depending on the location, there can be focal neurological deficits, probably in the form of hemiparesis or hemiplegia. They can have vision loss. Patients can also have they can also have breathing difficulties, and most of these patients with intracerebral hemorrhage, or even extra, even the subdural, extradural, or subarachnoid hemorrhage, these patients can also develop seizures. Seizures are also not uncommon in patients with traumatic brain injury. They can be early during the phase of illness, or they can develop even late. In the acute period, they may not have seizures, but they can develop seizures late in their lives. And the most dreaded complication is being comatose. Whenever there is injury to the brainstem, or the critical pathways concerned with the bulbar muscles, all the respiratory muscles, they can also become comatose, and they may need ventilator, they may need tracheostomy. So the clinical features can range from mild to very severe. So moving on to investigations. How do we investigate these patients? Uh, Basically, the first and foremost thing is that whenever we have a case of trauma, we need to screen them at the bedside. We need to see if these patients have only head injuries, or they have injuries anywhere else on the body, because most of these patients are not conscious when they present to us. So we need to find out if there are any other injuries. Like, for example, in patients with head injury, cervical spine injuries are also common. So we need to clinically assess for possible injuries. They can have chest wall injuries, they can have abdominal intra-abdominal hemorrhage, they can have pelvic fractures also along with this. So we need to screen them bedside, and then we proceed to do their brain imaging. Brain imaging is the most crucial investigation in these cases. We preferably we do a CT scan first, because it is very quick, and CT scan is very sensitive to pick up hemorrhages. So initially we do CT scans, where we can find if there are any skull fractures, if there are any hemorrhages. And if sometimes, rarely, CT scan can be normal. And but if the patient continues to remain comatose or in a bad state, we need to do an MRI scan. MRI scan is required to diagnose cases with, sometimes we need MRI to diagnose cases like diffuse axonal injury, where CT scan can be spuriously normal. So that is the investigations part. And to assess for hemorrhages elsewhere, we may need to do a cervical spine screening, like a CT scan of the spine, and we may have to do a chest X-ray or a chest CT, ultrasound abdomen and pelvis, or CT abdomen and pelvis, to screen them for other sites of injury. In the clinical features, one thing that I forgot to mention, and which is very important for you to write in the exams, is assessment of Glasgow Coma Scale. Basically, this is a scale that was developed to objectively uh, document the level of consciousness in patients. So this involves three parameters. One is eye opening, two is motor movements, and three is verbal response. So this is, we score it over 15 points, 15 being the best score, while three being the least score. So if a patient is comatose, totally comatose, that patient will score 3 on Glasgow Coma Scale. That is 3 out of 15. But if a patient is totally conscious and oriented and following your commands, this patient will score 15 out of 15. They fall under the category of mild traumatic brain injury, while a patient with scoring 3 on 15 will fall under the category of very severe traumatic brain injury. So that completes our clinical features and investigations part. Then how do we manage? So management includes, like any other emergency, you first need to take care of A, B, C. That is airway, breathing, and circulation. So you need to make sure that the patient is able to breathe and there is no physical obstruction. If required, we may need to secure an airway. That is, put them on, intubate them and put them on ventilator. And then assess their breathing part. We need to make sure that their oxygen saturations and all normal. And then circulation. We need to check their blood pressure because most of these patients would have lost a lot of blood. So they may need fluid replacement, or sometimes even uh, blood products need to be transfused in such cases. So after we initially stabilize them and then we do a scan, we get to know what is the kind of injury. In mild traumatic brain injury cases, we can manage them conservatively or medically. So the main goal is to see that there is no raised intracranial pressure. So intracranial pressure reduction forms the major part of the crucial part of head injury. So there are drugs which are called osmotic diuretics like mannitol or hypertonic saline, which is 3% normal saline. We use these to reduce the intracranial pressure. If the medical management is successful, we don't need to resort to surgery. But in some patients, the intracranial pressure may not be adequately controlled medically, or the injury might be very severe, or there may be hemorrhage within the brain parenchyma or outside the brain parenchyma, and we may have to go for emergency surgeries. For example, in case of extradural hemorrhage, if it is significantly big enough, or it is causing compression on the brain parenchyma, or it is causing midline shift, we may have to do a burr hole and urgently evacuate the blood which is there in between the skull and the epidural membrane. Similarly, even if the intraparenchymal hemorrhage also is causing midline shift, or the subdural hemorrhage is causing midline shift, we have to uh, surgically manage these patients. The complications of any prolonged bedridden state, like deep venous thrombosis or pressure sores or ulcers, these are common even in cases of head injuries. We need to take care of that. We need to take care of their nutrition also, because most of them are dependent on drugs. So we may have to put them on nasogastric tube, or if the patient is in vegetative state for a long time, they may need endoscopic procedures like PEG, percutaneous endoscopic gastrostomy, to prevent them from developing malnutrition. So I think that concludes our question on head injuries. Let's move on to the next question. Sorry. So 2A is muscular dystrophies. Muscular dystrophies are inherited disorders with progressive muscle destruction. They may be associated with cardiac or respiratory involvement, and sometimes they can also have other non-myopathic features. These muscular dystrophies can be myotonic or non-myotonic. Myotonic muscular dystrophy is the most common form of muscular dystrophy, with a prevalence of about 12 in 1 lakh. So what are the clinical features? The pattern of clinical features is defined by the specific syndrome. Often the onset is in childhood, although some patients, especially those with myotonic dystrophy, may present in adulthood. Wasting and weakness are usually symmetrical without fasciculations or sensory loss. And tendon reflexes are also preserved until late stages. So, muscular dystrophies are pure motor syndromes caused by progressive muscle destruction, and these are inherited disorders. They have a genetic mechanism and they are inherited from one generation to the other. So, because it is a pure motor syndrome, there is only weakness, which is symmetrical, but there is no sensory loss. The tendon reflexes are also relatively preserved until the last stages, where once the disease is very severe, they may also have loss of deep tendon reflexes. In most of the cases, the weakness is usually proximal. That is, shoulders as well as hips are the joints where the weakness is severe. But there are exceptions, like, for example, myotonic dystrophy type 1, where the weakness can be distal. So let us discuss some of the muscular dystrophies individually. First, let us discuss the myotonic muscular dystrophy, which is myotonic dystrophy type 1. This is an autosomal dominantly inherited conditions due to triplet repeat chromosome 19q. So the age of onset can be anywhere. It can range from childhood to adulthood, but usually this is the one that presents early in the adulthood. So the muscles affected include predominantly the face, which causes bilateral facial weakness. There can be ptosis. Ptosis is difficulty in opening eyelids completely. So they can have ptosis. Because of facial palsy, they can have wasting of their temporal muscles. There can be wasting of their sternocleidomastoid, that is the neck muscles, and these patients have significant neck drop. They can also have distal limb weakness in the form of hand grip weakness or even foot weakness. Other associated features in myotonic dystrophy are myotonia, which is sustained contraction or difficult, abnormally sustained contraction or difficulty in relaxation, basically. So they can have myotonia, they can have cognitive impairment. These patients can have cardiac conduction defects. They can have cataracts or lens opacification. They can have frontal baldness, or they can also have hypogonadism. Then there is myotonic dystrophy type 2, which is also known as proximal myotonic myopathy. Sorry. This is also autosomal dominantly inherited condition because of repeat expansion in zinc finger protein 9 gene, which is on chromosome 3q. Age of onset can be anywhere between 8 years and 50 years. It usually affects the proximal muscles, especially the thighs. Rarely, these muscles can show muscle hypertrophy also. So other features include myotonia, similar to myotonic dystrophy type 1, but cognition is relatively spared in myotonic dystrophy type 2. So these two are type 1 and type 2 are myotonic muscular dystrophies. From there, let us move on to non-myotonic muscular dystrophies. The most common or the most important dystrophy for us is Duchenne muscular dystrophy and Becker's muscular dystrophy. Duchenne muscular dystrophy and Becker's, these are called dystrophinopathies. These are X-linked diseases. They are inherited via X-linked mechanism because of deletions in dystrophin gene, which is located on the X chromosome. In Duchenne muscular dystrophy, the age of onset is less than 5 years. Predominantly proximal and limb girdle muscles are affected, and associated features can include cardiomyopathy or respiratory failure. Whereas Becker muscular dystrophy is similar to Duchenne muscular dystrophy. It is similarly inherited via X-linked mechanism. And then the deletion of dystrophin gene is also the common pathophysiological mechanism. But the age of onset is slightly later when compared to Duchenne muscular dystrophy. So it can start beyond 5 years or sometimes even in early adulthood. Even in Becker's, it is proximal and limb girdle weakness, which is most common. These individuals also can have cardiomyopathy, but respiratory failure is not as common as in Duchenne muscular dystrophy. Other non-myotonic muscular dystrophies are called limb girdle muscular dystrophies. They are also known as LGMDs. There are, this is a group of many diseases. There are many mutations which are known, and the inheritance pattern also can vary. It can be autosomal dominant or autosomal recessive. And similarly, they can have childhood onset or adulthood, early adulthood onset. But these predominantly involve the limb girdle muscles. And their clinical manifestations, other clinical manifestations also can vary. Some of them can have cardiac conduction deficits or cardiomyopathies or respiratory paralysis. Another important muscular dystrophy, a unique muscular dystrophy, is called facioscapulohumeral dystrophy. It is called FSHD, facioscapulohumeral dystrophy. Easy to remember the clinical features because it is the name suggests it. So there is predominantly weakness of facial muscles and upper limb girdle. Basically, the scapular muscles are weak, and there can also be upper limb muscle weakness. This is also inherited autosomal dominantly, and the mutation is in chromosome 4q. The age of onset can be, it can have a bimodal age of onset. It can occur early in the childhood, probably the second decade, or it can sometimes be late, even occurring beyond 30 years. So, in addition to weakness of muscles, they can have pain in the shoulder girdle, and they can also have deafness. Sensory neural deafness is a common feature, associated feature in facioscapulohumeral muscular dystrophy. Another rare entity is oculopharyngeal muscular dystrophy. It is also known as OPMD. Autosomal dominant and recessive inheritance patterns are known. This is one muscular dystrophy which can occur very late, as late as 60 years also. The onset can be at around 60 years also. Again, as the name suggests, ocular features are prominent here. What ocular features are there? There can be ptosis, that is difficulty in opening eyelids, or there can be ophthalmoplegia, external ophthalmoplegia, that is extraocular eye movements are also impaired in these patients. In addition to that, they can have dysphagia and tongue weakness. So, in addition to these bulbar features, they can have mild limb weakness as well. But the unique feature here is that it starts very late. The onset is can be as late as 6th decade or 7th decade. Another muscular dystrophy is Emery-Dreifuss muscular dystrophy. It is an X-linked recessively inherited disease where the onset can be around 4 to 5 years of age. Humeroperoneal muscle pattern of weakness is seen. That is, the upper limb, shoulder or the humeral muscles are involved, proximal upper limb muscles, as well as peroneal, that is, the foot muscles are also involved. The girdle muscles or the proximal weakness can occur later in the illness. But the most important or the unique feature of Emery-Dreifuss muscular dystrophy is early contractures. Especially elbow contractures are seen very early in the disease, and that's a unique feature of Emery-Dreifuss muscular dystrophy. Cardiac involvement leading to sudden cardiac death is also described in Emery-Dreifuss muscular dystrophy. So these are the clinical features of the individual types of muscular dystrophy. So you need to mention the clinical features first as an outline, and then you can describe the individual muscular dystrophies with in some detail. Then we move on to the investigations. Currently, the most important investigation or investigation of choice for muscular dystrophy is molecular genetic testing, because there is a genetic basis for all these diseases. Molecular genetic testing is an easy tool to diagnose muscular dystrophies. In cases where the genetic testing cannot be done, or sometimes when it is unrevealing, then you can go for other tests like electro EMG, needle EMG. It is called electromyography, where we see the pattern of muscle weakness, or we may have to do a muscle biopsy also, so that we can subject it to histopathology and immunohistochemistry. Creatinine kinase is one simple enzyme. It is checked in the serum. So it's a simple blood test. Basically, it is used to screen because creatinine kinase is markedly elevated in cases of muscular dystrophy, especially Duchenne and Becker's muscular dystrophy. In some patients these days, we also do muscle MRI, where we see the pattern of weakness or pattern of involvement of muscles in various limbs, and we try to diagnose which muscular dystrophy this patient might be suffering from. In addition to diagnosis, we may have to screen them for cardiac conduction deficits or other problems. So once we diagnose, how do we manage them? A definitive therapy for most of the muscular dystrophies is lacking. So it is mainly supportive therapy that we need to give, like physiotherapy and occupational therapy and preventing complications. But in certain conditions like Duchenne and Becker's muscular dystrophy, we can give glucocorticoids because glucocorticoids are known to slow the progression of Duchenne muscular dystrophy, so they can be given. But of late in the past decades, gene therapy has been developed to treat these cases. So we have gene therapy examples like ataluren or viltolaren, or there are other drugs which have been developed. So they basically, what gene therapy does is it prevents the gene mutation from expressing itself, so that the manifestations of muscular dystrophy are not seen, and the child continues to grow, or the grows with minimum deficits. So I think that should be adequate when you're answering a question on muscular dystrophies. So let us move on to the next question, which is 2B. That is, write in detail about etiology, clinical features, investigation, and management of middle cerebral artery stroke. So first, when a question is asked on any stroke for that matter, you need to define stroke. Stroke is acute focal brain dysfunction due to vascular disease. Stroke is defined as acute focal brain dysfunction due to vascular disease. So the vascular, as we know, the brain's vascular system has arterial as well as venous components. So venous strokes they're very rare. It can lead to a condition called cerebral venous sinus thrombosis. So rarely they are seen. But that is a separate, that's a different topic. So today we'll not be discussing that. You can go back to your text and read this part on venous strokes also. That is cerebral venous sinus thrombosis. So now coming to the arterial system. So the brain's arterial system can lead to two kinds of strokes. One is ischemic stroke. The second is hemorrhagic stroke. Excuse me. Ischemic stroke is due to lack of blood supply to a part of brain. Hemorrhagic stroke is hemorrhage inside the brain due to rupture of blood vessels. So here today we'll be discussing ischemic stroke, that is infarcts. So in infarcts also we can classify it based on the site of lesion. So the ischemic stroke can be in the anterior circulation or posterior circulation. Anterior circulation includes anterior cerebral artery, middle cerebral artery, whereas posterior circulation includes the vertebral arteries and basilar artery and its branches. So coming to the anterior circulation, which forms nearly 65% of patients of all infarcts, we have types of anterior circulation strokes. One is total anterior circulation stroke, the other is partial anterior circulation stroke, or the last are lacunar strokes. So in total anterior circulation stroke, one major blood vessel gets entirely blocked, leading to extensive tissue destruction and infarct. In partial anterior circulation, only a branch of the major blood vessel gets clogged. So the damage or the infarct size is not as extensive as in total anterior circulation. When coming to lacunar strokes, these are caused by the blockade of penetrating blood vessels. These are small blood vessels which cause mainly which supply the subcortical structures, leading to lacunar strokes. So total anterior circulation stroke and partial anterior circulation stroke, this is where our middle cerebral artery needs to be described. How is middle cerebral artery formed? It arises from the internal carotid artery. So ICA divides to form the middle cerebral artery. Middle cerebral artery again has multiple divisions, like it is called M1, then M2, superior and inferior division of M2, then M3 and the peripheral vessels. So that is the basic. You need to describe the various kinds of strokes, and if possible, if you have time, you may draw a diagram of circle of Willis also, so that you denote the middle cerebral artery well. So after describing what is stroke, now we need to get into the mechanisms of stroke. So stroke or infarction, cerebral infarction is mostly caused by three mechanisms. One is thromboembolic disease, two is cardioembolic disease, three is thrombosis in situ. That is, thromboembolic disease means there is atherosclerosis in one blood vessel, one major blood vessel, and these atherosclerotic plaques get dislodged and they go and block another blood vessel distally. So this leads to thromboembolic phenomenon. The second mechanism is cardioembolic. In patients with heart disease, due to some reason, there can be formation of clots inside the heart, and from there they reach the cerebral circulation. This is called cardioembolism. Or the third mechanism is thrombosis in situ, where the small penetrating blood vessels they get clogged. There is atherosclerosis inside these small branches, which are called lenticulostriate arteries, and they get clogged and they lead to stroke. In addition to this, sometimes rarely patients can have underlying vascular diseases like vasculitis, or other mechanisms could be hyperviscosity state of the blood, where there is a tendency for the patient to form clots or the blood to get uh, clotted, like in certain hemoglobinopathies, or in conditions like sickle cell disease, or thrombophilias, where they are genetic conditions where they are predisposed to developing thrombosis. For example, protein C, protein S deficiencies, factor V laden mutations. So all these factors also can be the underlying mechanism in a patient with stroke. Then we need to discuss certain risk factors for stroke. What are the risk factors of stroke? They can be modifiable or non-modifiable. Non-modifiable risk factors are age. Advanced age is a non-modifiable risk factor. Male gender is a non-modifiable risk factor. Afro-Caribbean or Asian race is a non-modifiable risk factor. Previous vascular events like myocardial infarction, stroke, or peripheral vascular disease, or genetic mutations, heredity, or high fibrinogen levels, these are all non-modifiable risk factors. Modifiable risk factors could be blood pressure, cigarette smoking, hyperlipidemia, diabetes, heart disease, or heart diseases like atrial fibrillation, cardiac failure, infective endocarditis, or excessive alcohol intake, or conditions like polycythemia, or in women who take hormonal replacement therapy or oral contraceptive pills. These could be modifiable risk factors. Now we need to describe the symptoms which are unique to middle cerebral artery stroke. So if you see in a patient with total middle cerebral artery circulation syndrome, that is total anterior circulation syndrome due to middle cerebral artery, there can be a combination of hemiparesis, which is usually contralateral. That is, if you have left MCA infarct, patient will have right hemiparesis or hemiplegia. Patient can also have higher cerebral dysfunction. Like for example, if there is infarct on the left hemisphere or the dominant hemisphere, patient can have aphasia. Patient can have contralateral hemisensory loss. Patient can have contralateral hemianopia also. But the unique feature of middle cerebral artery circulation strokes is that the upper limb is more involved than the lower limb. There is relative sparing of lower limb because of the arrangement of fibers in the motor homunculus. So the area that the middle cerebral artery supplies predominantly involves the facial as well as the upper limb muscles, where the lower limb muscles which are present near the midline are spared. So the common causes of total anterior circulation syndrome are middle cerebral artery occlusion. In partial anterior circulation syndrome, there can be a mixture of these features. There can be only hemiparesis, only Upper limb weakness can be there, only facial weakness can be there, aphasia may or may not be there, hemianopia may not be there. So these are all features of partial anterior circulation syndrome. In lacunar syndrome, it can be a pure motor stroke. This causes dense hemiparesis because it occurs in the subcortical structures where the muscle fibers are tightly packed. The upper limbs and lower limbs can get involved together. Even if the stroke or the infarct looks small on the scan, it can lead to extensive weakness. So pure motor strokes, it can cause pure sensory stroke, sensory motor strokes, or ataxic hemiparesis is also a feature of lacunar stroke syndromes. So what are the investigations that we do in a case of suspected stroke? The most important investigation is brain imaging. We can do a computed tomography, which is CT scan or an MRI. So this will tell us whether it is a vascular lesion or not. It will tell us whether it is ischemic or hemorrhagic. It will tell us whether there is any subarachnoid hemorrhage or other disease also. And there's angiography also. We can do angiography using MRI or CT, where it will tell us the status of the large blood vessels like internal carotid artery, middle cerebral artery, ACA, or basilar artery. So to look for underlying causes, we may have to do a screening of their cardiac system. We may have to do ECG, echocardiogram, Holter monitoring, or we may have to do other risk factor assessment like blood counts, cholesterol levels, blood glucose levels, and sometimes even serum protein electrophoresis or genetic testing may be required. So once we diagnose, how do we treat? In the acute phase, if a patient with middle cerebral artery stroke presents to us within the window period, which is 4.5 hours for IV thrombolysis. That is, we inject a drug intravenously if the patient presents to us within 4.5 hours. So what it does is it causes thrombolysis. It lyses the clot and the circulation to that area of the brain is restored. So within first 4.5 hours, we can do IV thrombolysis. If a patient presents to us beyond 4.5 hours, but within 6 to 24 hours, we can do a procedure called mechanical thrombectomy also. Endovascularly, we can reach the particular blood vessel, whichever is the culprit, and we try to retrieve the clot so that the blood circulation gets restored. So these are acute treatments. Then we need to look at secondary prevention of stroke also in such patients. The most important drugs here are antiplatelets. For example, aspirin or clopidogrel or ticagrelor. And for prevention, we may also have to use statins like atorvastatin or rosuvastatin. What are the complications of stroke? Epileptic seizures. So in such patients, we may have to add anticonvulsants. Some patients can have depression and anxiety. We have to use antidepressants in them. Some patients can develop painful shoulder, which is called periarthritis. For them, we have to do physiotherapy. They can develop chest or urinary tract infections where we may have to use antimicrobials. We have to prevent pressure sores in them. So frequent turning and position change is important. And then we also have to prevent deep venous thrombosis in patients who are bedridden for a prolonged time. You also need to take care of their nutrition, airway, breathing, circulation, blood glucose status, temperature. And if they're incontinent, you may have to take care of their urinary catheters also. So that brings us to the end of essay questions. Now let us rapidly discuss the short notes. So the first one being carpal tunnel syndrome. Carpal tunnel syndrome is basically it is median nerve entrapment at the wrist. So carpal tunnel syndrome is the most common entrapment neuropathy. Entrapment occurs in the tunnel where the medial nerve and the long finger flexors pass. So here is the site where there is compression. Because the transverse carpal ligament which is there, it's a hard fibrous structure, thick fibrous structure which forms the roof of the canal. So tenosynovitis or arthritis in this area can lead to pressure on the median nerve. This leads to various symptoms of carpal tunnel syndrome. What could be the symptoms? Symptoms could be nocturnal pain, paresthesias, most often confined to these three fingers, which is thumb, index, and the middle finger. So most often the symptoms are experienced in these three fingers. Sometimes when it gets severe, symptoms may be experienced in the entire hand. Patients can experience tingling and numbness and burning sensation in these fingers or the hand. They are often very severe that the patients get awakened from sleep. Rarely, when it is severe, there can be referred pain even proximally in the forearm. So excessive use of hand is the culprit here. Basically, while using a phone for a long time or reading a book or holding a newspaper, all these things can worsen carpal tunnel syndrome or lead to carpal tunnel syndrome. Sensations like pinprick also can be impaired over these fingers. Typically, the sensations over the thenar eminence are not affected in carpal tunnel syndrome because that nerve comes proximal to the carpal tunnel. So it is not affected. Sorry. So how do we diagnose? Bedside, there is a test that you can do. It's called Fallon's maneuver. You ask the patient to do this and maintain this posture for for a minute at least. So you ask them to maintain this position. So if they experience the symptoms, then it is predictive of carpal tunnel syndrome. There is another sign called reversed Fallon maneuver, where you ask the patient to keep their hands like this for a minute. And if the symptoms are developed, then it can be, you can suspect carpal tunnel syndrome in them. A positive Tinel sign is also a feature of bedside clinical feature of carpal tunnel syndrome. So the main cause is work-related wrist and hand movements. Basically, repetitive motion injury is the culprit in worsening or causing carpal tunnel syndrome. There are certain diseases which can worsen carpal tunnel syndrome. For example, pregnancy, diabetes, obesity, rheumatoid arthritis, hypothyroidism, amyloidosis, acromegaly. These are all causes which can worsen carpal tunnel syndrome. How do we diagnose? Once we have clinical suspicion, we do tests like nerve conduction studies, which are electrodiagnostic studies, where we look for conduction derangement in the median nerve. We may also do EMG, needle EMG in these patients. Nerve ultrasound can also pick up changes of carpal tunnel syndrome, and in rare cases, we can also do an MRI scan of the wrist. So once we've diagnosed, how do we manage? The simple treatment includes non-steroidal anti-inflammatory drugs like probably paracetamol or aceclofenac, NSAIDs. And then we can ask the patient to go for splint, a wrist splint where the movements are minimized. If that fails to help the patient, we can also resort to methylprednisolone injections in the carpal tunnel. So we can locally inject them. Oral steroids are also known to give some relief to the patients. If all this medical management fails, we can also go for open surgical sectioning of the carpal ligament, or fiber optic techniques can also be used to relieve the pressure over the median nerve. So that concludes our question on carpal tunnel syndrome. The next question is uh, differences between upper motor neuron and lower motor neuron lesions. So upper motor neuron lesions are lesions that occur in the central nervous system, whereas lower motor neuron lesions are the ones that occur in the peripheral nervous system. So upper motor neuron lesions can be in cerebral hemispheres, cerebellum, brainstem, or spinal cord, while lower motor neuron lesion starts from anterior horn cell, nerve roots, peripheral nerves, neuromuscular junction, or muscle itself. So the structures involved are these. And how is the weakness? Weakness in upper motor neuron lesion can be quadriplegia, hemiplegia, diplegia, or paraplegia. But the pathognomonic pattern of weakness in element lesions is usually, in myopathies it is proximal, in neuropathy it is distal. What happens to the muscle tone? Muscle tone in UMN lesions is increased. That is, they have spasticity or rigidity. While in LMN lesions, muscle tone is reduced. That is, it leads to hypotonia. So UMN hypertonia, LMN hypotonia. Fasciculations are present in LMN type of lesions. Fasciculations are absent in UMN lesions. How are deep tendon reflexes? In upper motor neuron lesions, there is hyperreflexia. You have exaggerated reflexes, deep tendon reflexes, whereas in lower motor neuron lesions, the deep tendon reflexes are hypo, or there is areflexia. Superficial reflexes like abdominal reflex is absent in UMN, whereas it is present or intact in LMN. Sensory loss in UMN, sensory loss can be there in UMN as well as LMN. But cortical sensory loss is predominantly seen in UMN, whereas peripheral sensation loss is seen in LMN. And the sensory loss in LMN is usually severe. And the next thing is atrophy. Atrophy is more common in LMN lesions. Atrophy or thinning of muscles is common in LMN lesions, where it is not so common in UMN lesions. So I think that's how we need to describe upper motor neuron versus lower motor neuron lesions. Let's move to the next question. That is clinical features of SMA or spinal muscular atrophy. So spinal muscular atrophy is a group of genetically determined disorders affecting the spinal cord and lower cranial lower motor neuron uh, lesions, basically. So it involves the spinal as well as cranial lower motor neuron lesions, which are the anterior horn cells, basically, characterized by proximal and distal wasting, fasciculation, and weakness of muscles. Involvement is usually symmetrical, but occasionally localized forms are also known. The progression is slow. It is basically motor neuron disease also is anterior horn cell disease. Spinal muscular atrophy is also a form of anterior horn cell disease, but the prognosis is slightly better than that for motor neuron disease. This we have to, the most important thing is we need to discuss the types of SMA. So SMA is, there are 5 types of SMA that are described. Type 0, type 1, type 2, type 3, type 4. Type 0 is known as prenatal variant, prenatal type of SMA, where the age of onset is prenatal. When the by the time the child is born, at that time itself, the child has respiratory difficulties. There is respiratory weakness. Child needs respiratory support right after birth. It is usually fatal without respiratory support. It is inherited autosomal recessively, and the defective gene is SMN gene. The next one, or the SMA type 1, is also known as infantile SMA, where the age of onset is between birth to 6 months. So the patient is, the child is able to sit with support, but beyond that, the patient may not, patient's motor milestones may not progress. Death usually occurs by the age of around 2 years. The SMA type 2 is called intermediate SMA. The onset is before 1.5 years, which is around 18 months. The patient, the child grows to sit independently, but beyond that, there is no development. The child cannot walk, and usually death happens in the adulthood. SMA type 3 is also known as juvenile. This in this disease, the onset is beyond 18 months. That is usually early or late in the childhood. The child walks independently, but there is proximal weakness, and usually the survival is not beyond adulthood. Type 4 SMA is also known as adult onset SMA, where the age of onset is beyond 5 years, but mostly it is after 30 years of age of onset. And the individual walks normally. There is only despite the patient walking independently and normally, there is some slow progression, and proximal or distal weakness can be there. It can be in the form of difficulty in holding objects or difficulty in holding footwear. All the other SMA types, type 0, 1, 2, 3 occur, they occur autosomal recessively, whereas adult onset SMA or the type 4 SMA can occur autosomal recessively or autosomal dominantly, or it can be sporadic also. So due to lack of time, I'm moving on to the next question, which is autonomic dysreflexia. Autonomic dysreflexia or autonomic hyperreflexia is the product of dysregulation of the autonomic system, which is imbalance between sympathetic and parasympathetic system, leading to an uncoordinated response to a painful stimulus below the level of a spinal cord injury. This is most commonly seen in patients with spinal cord injury, uh, and the injury, the spinal cord injury occurring at or above thoracic T6 vertebral level. So whenever there is a severe spinal cord injury above T6 level, we notice this autonomic dysreflexia. Clinically, autonomic dysreflexia is defined as an acute episode of systolic blood pressure elevation by at least 25 mm of mercury in in a patient whose blood pressure was otherwise normal. So acute episode of elevated blood pressure should ring a bell in your mind, and you need to think of autonomic dysreflexia. What is the pathophysiology in a patient with spinal cord injury? The normal sympathetic response from the medullary vasomotor center cannot travel below the level of spinal cord injury. And this leads to generalized vasoconstriction affecting the splanchnic, muscular, vascular, and cutaneous arterial circulatory networks. This leads to systemic hypertension, which is often severe and potentially life-threatening. The compensatory vagal and parasympathetic stimulation leads to bradycardia and vasodilatation, but only above the level of spinal cord injury. So there is imbalance between sympathetic and parasympathetic innervation and above and below the lesion also. So this leads to acute state. So what are the signs and symptoms? Severe paroxysmal hypertension associated with throbbing headaches. There can be flushing of skin, bradycardia, there can be cognitive impairment, there can be increased spasticity and constricted pupils also. So what are the complications of autonomic dysreflexia? It can lead to pulmonary edema, left ventricular dysfunction, retinal detachment, intracranial hemorrhage, seizures, cardiac arrest, encephalopathy, myocardial infarction, or sometimes even death. Let's move on to our next question, which is tabes dorsalis. Tabes dorsalis is an infectious radiculopathy. It is the most common form of late neurosyphilis, which begins as a spirochetal meningitis that is caused by spirochete named Treponema pallidum. After 10 to 20 years of persistent infection, there is damage to the dorsal roots, which is severe and extensive and producing symptoms characteristic of tabes dorsalis. So this is basically a late neurosyphilis affecting the spinal cord, especially the dorsal roots. Symptoms include lightning pains, ataxia, bowel and bladder disturbances, whereas signs include Argyll Robertson pupil, areflexia, loss of proprioceptive sensations, or trophic ulcers. There can be sensory disturbances in the form of tingling and numbness, and there can also be sometimes episodes of visceral crisis characterized by abrupt onset of epigastric pain that spreads around the body and over the chest also. Most common features are explained by the lesions in dorsal roots, dorsal root ganglia, or posterior columns in the spinal cord. So how do we diagnose? After we see, we have the clinical features, we do an imaging, and then we can do CSF analysis also. CSF analysis will show mild lymphocytic pleocytosis, that is increase in lymphocytes in the CSF with elevated protein concentration. So the proteins also get elevated. And in these patients, we do serum treponemal test as well as CSF VDR, which turned to be positive. Then our suspicion of neurosyphilis or tabes dorsalis can be confirmed. And then the patients are started on the pharmacotherapy. The drug of choice here is IV benzyl penicillin. So we give 2 to 4 million units IV every 4 hours for 14 days. An alternative could be ceftriaxone. In patients who are allergic to benzyl penicillin, we can give ceftriaxone also. Moving to the next question, cranial nerves. Cranial nerves, as we know, they are basically 12 cranial nerves in the body. You need to name them and you need to tell where they originate and what structures are innervated by individual cranial nerve and what are the functions observed by this cranial nerve. So, for example, olfactory nerve, it originates in the olfactory bulb, basically, and then the peripheral, or it terminates in the olfactory epithelium. It is concerned with the smell function. The second is optic nerve. Optic nerve, it arises in the lateral geniculate nucleus, superior colliculus, and then it ends in the retinal ganglion cells. Mainly concerned with vision. Oculomotor nerves associated with eye movements as well as eyelid. Basically, eyelid opening is also a function served by oculomotor nerve. Fourth is trochlear nerve, which supplies the superior oblique muscle, and then it is also involved with extraocular eye movements. Optic nerves, cranial nerve 6 is known as abducent. It innervates the lateral rectus. So the abduction of eye is the functions observed by abducent nerve. Fifth is trigeminal nerve. It has both motor and sensory functions. Similarly, seventh is facial nerve. Eighth is vestibulocochlear. Ninth is glossopharyngeal. 10th is vagus. 11th is spinal accessory nerve. And 12th is hypoglossal nerve. We need to describe the individual structures that are innervated by these cranial nerves and the function that they serve. Due to lack of time, I am proceeding on to the next question. Brainstem reflex. Basically, a reflex is an involuntary response to a sensory stimulus. Afferent impulses arising in a sensory organ produce a response in the effector organ. There are segmental and suprasegmental components to a reflex. The segmental component is a local reflex center in the spinal cord or in the brainstem, and it has an afferent part, a nucleus, and an efferent part. While the suprasegmental component is made of descending central pathways that control this particular reflex. They can increase, decrease, or modulate this reflex. So there is a segmental component which has an efferent part, and the nucleus. While the suprasegmental component, basically it modulates the segmental component. So what are the common brainstem reflexes that are clinically important? One is pupillary light reflex. Second is accommodation reflex. Third is jaw jerk. The next is vestibulo-ocular reflex or oculocephalic reflex. And another reflex is gag reflex. And the last would be ciliospinal reflex. So pupillary light reflex, basically the afferent is optic nerve and the efferent is oculomotor nerve. In accommodation reflex also, afferent is optic, efferent is oculomotor nerve. In jaw jerk, both the afferent and efferent are trigeminal nerve. And in vestibulo-ocular reflex, basically this is concerned with the balance, the labyrinthine system of the body. And in gag reflex, the afferent and efferents are 9th and 10th cranial nerves. In ciliospinal reflex, the afferents are basically in the neck, and they basically what this reflex is. This is not tested very often, but ciliospinal reflex, what it does is whenever there is a noxious stimulus to the skin over the neck, there is constriction of pupil. So this way you need to describe brainstem reflexes. You need to name all the reflexes, then where they are located, the afferent component, the efferent component, and where the synapse occurs. So all this has to be mentioned. Moving on to the next question, that is hydrocephalus. Hydrocephalus is excessive accumulation of CSF within the brain. It may be caused by either increased CSF production or reduced CSF absorption or obstruction of this circulation anywhere. So symptoms can range from sometimes simple symptoms like headache to when the obstruction is very severe, it can even lead to sudden death. Patients can become drowsy, they may have difficulty in walking, they may have urinary incontinence, so they may have memory loss. All these things could be symptoms of hydrocephalus. What are the causes of hydrocephalus? It can be acquired or congenital. Congenital include aqueduct stenosis, Kyrie malformation, Dandy-Walker syndrome, benign intracranial cysts, vein of Galen aneurysms, or craniofacial abnormalities. While the acquired causes could be tumors, mass lesions in the posterior fossa, colloid cyst of third ventricle, abscesses, tuberculosis, infections like meningitis, sarcoidosis, or intracranial hemorrhage can also later on lead to hydrocephalus. Let's move on to the very short notes or the brief notes. Brachial neuralgia, or it is also known as brachial neuritis. Neuralgic amyotrophy, brachial neuritis, brachial neuralgia, all these mean the same. Basically, it represents an acute brachial plexopathy of probable inflammatory origin. So it starts with severe shoulder pain with probably sensory loss over the shoulder region. So severe shoulder pain preceding the appearance of patchy upper brachial plexus symptoms with motor and sensory involvement. Basically, any plexus lesion, what is basically brachial plexus lesion, what we see is it's a mixed syndrome. Patient will have sensory as well as motor symptoms. That is pain, numbness, paresthesia, tingling and numbness can be there. In addition to that, patients will also have weakness in the nerves distributed. And this particular weakness is not restricted to one nerve because brachial plexus gives rise to multiple upper limb nerves. So the weakness or the sensory loss is in a pattern that does not confine itself to one particular peripheral nerve. So there is extensive sensory as well as motor symptoms. This can be basically this brachial plexus lesions can involve upper plexus, lower plexus also. When upper plexus is predominantly involved, it is called as Erb's palsy, where the muscles involved are biceps, deltoid, rhomboids, and brachioradialis, and the sensory loss is over the deltoid muscle. When lower plexus is involved, it is also known as Klumpke's paralysis. All small muscles of the hand are involved. It leads to claw hand, and the sensory loss is predominantly in the ulnar border of the hand and forearm. Sometimes thoracic outlet syndrome also can lead to brachial plexopathy. Other causes of brachial plexitis are diabetes, malignancies, trauma, hemorrhage, or infections like herpes zoster. All these things can lead to neuralgic amyotrophy or brachial neuritis. Next is apraxia. Basically, apraxia is a neurological symptom or neurological disorder characterized by inability to perform learned motor tasks. That is, tasks which already the individual is knows performing them. Inability to perform such learned motor tasks while the sensory and motor apparatus of the limb or the individual is normal. So, in the absence of sensory loss or paralysis of the limb, if an individual is not able to perform certain learned motor tasks, then we can think of apraxia in that patient. So what are the types of apraxias? Buccofacial or orofacial apraxias, ideomotor apraxia, ideational apraxia, or limb kinetic apraxia, or constructional apraxia, or oculomotor apraxia. I may not be able to go into the details of these. Please refer to the material in the text. And causes of apraxia could be anything. It could be vascular, it could be stroke, it could be infection, or it could be neurodegenerative diseases like Alzheimer's disease or frontotemporal dementia. So how do we diagnose? Diagnosis is by careful clinical examination and assessing higher mental functions of the patient. Treatment depends on the individual cause. Moving on to the next question, which is dyslexia. See, learning disability involving reading is known as dyslexia. Learning disabilities occur in approximately 10% of school-age children, and it can affect any of the one or more of the cognitive skills. So when particularly reading is involved, that particular learning disability is known as dyslexia. It is best studied in basically children. Nearly 10% of school-age children have some form of learning disability, and dyslexia is an important cause. Developmental dyslexia is an unexpected difficulty in learning to read. This definition, it contains both exclusive as well as inclusive criteria. It is basically the diagnosis is a little complicated. You need to take into consideration inclusive as well as exclusion criteria. So to simplify it, how do we diagnose is that basically educational institutions do this. They usually require that a child be reading 2 grades behind the actual or expected grade level for diagnosing dyslexia. That is, this is called 2 grades behind criterion. So if a child is expected to be in the fifth standard, if that child is still studying in the probably second standard or so, in that patient, we can think of dyslexia. They predominantly have difficulty in reading and difficulty with spellings. So there are multiple types of subtypes of dyslexia also, where language and memory can be affected in different proportions. So in one type, there can be no language or memory deficit. In second type, there can be global language and global memory deficit. In third subtype, there can be global memory deficit. But some of these children, if we, but a very few, a very small percentage of these patients, if they are provided adequate care, they can probably go on to, overcome this dyslexia and perform better in their studies. Moving on to the next question, that is balismus. Balismus refers to a dramatic neurological syndrome of wild, flinging, incessant, involuntary movements of the body parts. That is basically balismus is an involuntary movement. It's a hyperkinetic movement, and the movements here are very dramatic, and they are wild flinging movements of the arms or legs or any other part of the body. So these are wild flinging movements. Usually they occur only on one side of the body, and they are called hemibalismus, but they can occur bilaterally also. The affected region here is the contralateral subthalamic nucleus. Subthalamic nucleus is a subcortical structure. So lesions in this subthalamic nucleus can lead to balismus or hemibalismus. It is also seen in simple diseases like diabetes also. I'll quickly move on to the next question also because these are very short answers. This is Charcot's triad. Charcot's triad is actually, we have, this is Charcot's neurological triad is there, and there is Charcot's triad of cholangitis also. So here, because it is neurology, let us discuss Charcot's neurologic triad. Basically, it is seen in patients with multiple sclerosis. You can remember the triad using the mnemonic SIN, S-I-N. S stands for scanning speech, I stands for intention tremor, incontinence, and internuclear ophthalmoplegia. And N stands for nystagmus. So Charcot's classic triad of multiple sclerosis involves SIN, scanning speech, intention tremor, incontinence, internuclear ophthalmoplegia, and nystagmus. Charcot's triad of cholangitis is different, where fever, jaundice, and right upper quadrant abdominal pain are seen in cholangitis patients. Next question is Bell's phenomenon. Bell's phenomenon is basically, it's a physiological phenomenon. On closing the eyelid, the eyeball moves upwards and inwards. This is a naturally protective mechanism that the human body has developed. When any individual closes the eyeball moves upward and inward. So this is normally not appreciated. But in patients with lower motor neuron facial paralysis, that is, if let us say there is LMN facial paralysis on right side, when that individual tries to close the right eye, because of LMN facial paralysis, it does not close completely. In such patients, we can notice that the eyeball turns upward when they try to close the eye. The left eye closes normally, but the abnormal right eye, eyelid does not close, and we see the eyeball rotating upwards. This is known as Bell's phenomenon. It is seen in LMN facial nerve lesions. Next question is Romberg's test. Romberg's test was first described in patients with neurosyphilis. How it is done is, the patient stands with their feet touching each other. They stand straight with feet touching each other, and they look forward with eyes open. And the examiner stands right beside the patient to prevent any falls. And then the patient is asked to close their eyes. When a patient who is able to stand with eyes open but tends to develop imbalance while the eyes are closed, this is known as a positive Romberg test. So this is for, basically this is test for imbalance. It is positive when the patient has imbalance with when closing the eyes. So the patient may sway, the patient may fall completely. So we need to observe for a difference between the balance when the patient is standing with eyes open and eyes closed. So what does it mean? A positive Romberg test means there is proprioceptive sensory loss. Basically, this is seen in sensory ataxias and when there are falls due to sensory deficits. So in cerebellar disease, patient can have difficulty even with eyes open, but in so when patient has sensory loss, patient can stand with eyes open, but when the visual stimulus is lost, visual compensation is lost, they develop imbalance and they fall. In vestibular disease also, they tend to fall when they are subjected to Romberg test. Then the next question is amnesia. Amnesia is nothing but memory loss. Amnesia can be it can be classified in various ways. One way of classifying it is anterograde amnesia versus retrograde amnesia. In anterograde amnesia, basically new memory is not formed or not encoded after an insult to the brain. Whereas in retrograde amnesia, the individual loses memories of the past. If once there is an event, the individual loses the memory of the past which patient had earlier encoded. They are all lost. So that is called retrograde amnesia. whereas anterograde is patient failure to form new memories is anterograde amnesia. Other way of classifying it is working memory, immediate memory, long-term memory, and motor memory. So working memory or immediate memory is basically, it is a function served by prefrontal cortex. Short-term memory or episodic memory is a function of medial temporal lobe. Long-term memory, basically it is situated throughout, it is encoded throughout the multiple areas of the brain extensively. So it is there throughout the cortex, and it is very resistant. Only in advanced dementia patients lose their long-term memory. Then the next question is again reflex. Basically, as we discussed earlier, a reflex is an involuntary response to a sensory stimulus. Afferent impulses arising in a sensory organ produce a response in the effector organ. So you have an afferent pathway, and there is a nucleus or the center of reflex. So here you can describe the various types of reflexes in body. You have brainstem reflexes, then you have deep tendon reflexes, and you have superficial reflexes also. So deep tendon reflexes include jaw jerk, brachioradialis jerk, bicep jerk, tricep jerk, knee jerk, and ankle jerk. Whereas superficial reflexes can include corneal reflex, then you can have abdominal reflex, cremasteric reflex, and plantar reflex, or the which when abnormal is known as Babinski's sign. So that way you need to draw the reflex arc and describe these reflexes. The next question is tremor. Tremor again is a hyperkinetic movement disorder. Tremor is a series of involuntary, rhythmic, purposeless oscillatory movements. These oscillations can be either small amplitude or large amplitude. They can involve only one small part of the body or single muscle group, or they can involve multiple muscles. So the crucial part, the phrases that you need to mention here are involuntary, rhythmic, purposeless, oscillatory to and fro movements. So tremors can be classified in various ways. One way of describing them is whether they are occurring at rest or in action. So similarly, they are called rest tremor or action tremor or kinetic tremor or positional tremor. They can be low frequency tremor or high frequency tremor. They can be described on the basis of the rate, that is high frequency or low frequency, or they can be described on basis of the amplitude of the tremor also. So small amplitude or large amplitude tremors can also be there. Tremor is a hyperkinetic movement disorder. The most common diseases where we see tremors are Parkinson disease and essential tremor. But physiologically also tremor can be there. Tremor can be seen in when patient is anxious, or when patients have diseases like hyperthyroidism also, there can be tremor in such patients. So if you have any doubts, please feel free to reach out to me. I think we've come to the end of this session.
You can end the session, sir. Thank you.
Thank you.